So, hello everyone, and welcome to our Module 6, Part 2. And we are now going to discuss about sexual dysfunctions, gender dysphoria, and paraphilic disorders. So, these are three distinct disorder groups in the DSM-5, but I will just combine them into one lecture. So, without further ado, let's start with sexual dysfunctions. So what do we say or what do we mean when we say sexual dysfunctions? So sexual dysfunctions refers to a problem occurring during any phase of the sexual response cycle that prevents the individual or couple from experiencing sexual satisfaction from the sexual activity. So just to refresh to you about the sexual response cycle, so this traditionally includes the excitement phase, the plateau phase, the orgasm phase, and the resolution phase. So desire and arousal are both part of the excitement phase of the sexual response. So what are some sexual dysfunctions in both males and females? So firstly, male sexual dysfunction. These are from the DSM-5, and there are 4 sexual dysfunction that are specified to biological males. So firstly is delayed ejaculation. So this is delayed, infrequent, or absent ejaculation in at least 75% of the partnered sexual activity occasions. In the previous version of the DSM-4TR, this sexual dysfunction was referred to as male orgasmic disorder. So, but now it is renamed into delayed ejaculation. So, number 2 is erectile disorder. So, this is diagnosed when a male has 1, difficulty getting erections. Number 2, difficulty maintaining an erection. Or number 3, a decrease in how rigid the erection is during 75 to 100% of the sexual activity encounters. So, number 3 is the male hypoactive sexual desire disorder. So this is the lack of recurrent or decreased sexual thoughts, fantasies, and desire for sexual activity. It is the responsibility of the diagnosing clinician to determine that desire is not only perceived as low in comparison to the desire of one's partner, which would be a desired discrepancy between partners and may not be sexual dysfunction. Number 4 is premature or early ejaculation. So this is diagnosed when ejaculation occurs within 1 minute following vaginal penetration and before the person wishes it on at least 75% of partnered sexual activity occasions. It is important to note that this diagnosis is applicable to men who engage in non-vaginal sexual activity, but unfortunately, the specific duration of the criteria remains unknown. These are the 4 sexual dysfunctions for male. So how about female sexual dysfunction? So we have 3. These are specific to biological females. Okay? So first is female orgasmic disorders. So this is the delay in or infrequency of absence of orgasm or a reduced intensity of orgasmic sensations during 75 to 100% of sexual activity encounters. Since there is a lot of variations in the type or intensity of the stimulation that triggers orgasm. Clinicians are left to judge if a female's ability to orgasm is less than expected for her age, sexual experience, and stimulation received. Number 2 is female sexual interest or arousal disorder. It is the absent or reduced sexual interest or arousal. This is determined by meeting 3 or more of the following criteria. Number 1, reduced or absent interest in sexual activity. Number 2, reduced or absent sexual thoughts or fantasies. Number 3, reduced or no initiations of sexual activity or not responding to partner initiations. Number 4, reduced absent excitement or pleasure during 75 to 100% of sexual activity events. And number 5, reduced or absent interest or arousal in the context of any sexual cues. Or number 6, reduced or absent genital or non-genital sensations during 75 to 100% of sexual events. So the diagnosis of female sexual interest or arousal disorder is a combination of the female hypoactive desire disorder and the female arousal disorder from the DSM-4-TR. And the last sexual dysfunction for females that is indicated in the DSM-5 is the genitopelvic pain or penetration disorder. These are constant or repeated difficulties with number 1, vaginal penetration during intercourse, number 2, vaginal or pelvic pain during penetration, number 3, significant fear or anxiety about vaginal or pelvic pain, or number 4, tensing of the pelvic floor muscles during penetration attempts. So, genitopelvic pain penetration disorder is a combination of the diagnostic criteria for dyspareunia and vaginismus in the DSM-4-TR. So, male genital pain has been removed from the current version of the DSM because of insufficient research, even though there is a growing evidence for men experiencing pain during erection, ejaculation, and receptive anal intercourse. So, when we say dyspareunia, this is the recurrent genital pain caused by sexual activity. Meanwhile, vaginismus is the body's automatic reaction to the fear of some or all types of vaginal penetration. So, whenever penetration is attempted, your vaginal muscles tighten up on their own. So, you have no control over it. And occasionally, you can get vaginismus even though you have previously enjoyed painless penetrative sex. So, just remember, the genitopelvic pain penetration disorder is a combination of dyspareunia, which is pain experience whenever there is sexual penetration, and vaginismus, which is the involuntary tightening of the vaginal muscles. So, sometimes it may occur during penetration. So, I think you have heard of the best example of a certain celebrity. So, just remember that each of the sexual dysfunctions could be lifelong or acquired, generalized, or situational, and clinicians could specify whether the distress over symptoms is mild, moderate, or severe. And also note that not everyone agrees for the diagnostic criteria for all of these sexual dysfunctions. So there is a variety of ways that people can experience a distressing sexual problem. That being said, you might find yourself suffering from a sexual problem that doesn't quite meet the criteria above to be considered a sexual dysfunction. So if you are distressed by this problem and or it's negatively impacting your relationship, you should go to talk to a health professional. They can still help you out or point you in the right direction. So just remember, we also include sexual dysfunctions because sometimes sexual dysfunctions have a psychological cause. So for example, due to stress, extreme stress or distress sa person, that's why their sexual activity or their sexual performance in the bedroom is compromised. So I know that some of you are already sexually active, and I hope that this lesson about sexual dysfunctions can also help you in realizing if there are problems, especially during your sexual intercourse. But most of the time, these are done by couples. For females, so usually couples go to their OBGYN or their gynecologist, and for men, they go to their urologist and consult about their sexual activities and their problems when it comes to sex. But of course, there is also a role for psychologists like us. So we also have sex therapists. So I think if you watch Sex Ed, so that's also a primary example. Yeah, so we also have a role here as psychologists when it comes to the sexual activities of couples. So now let's go on to a very controversial disorder, which is gender dysphoria. So gender dysphoria is formerly classified as gender identity disorder in the previous version of the DSM or the DSM-4-TR. It is the formal diagnosis used by psychologists and physicians to describe people who experience significant dysphoria or discontent with the sex and gender they were assigned at birth. Many people who are diagnosed with gender dysphoria identify as transgender, gender fluid, or otherwise gender non-conforming in some way. However, not everyone who identifies as transgender or gender non-conforming experiences gender dysphoria. Gender dysphoria is a controversial diagnosis characterized by a person's discontent with the sex and gender they were assigned at birth. Symptoms of gender dysphoria in children include discomfort with their genitalia, feeling that they are a different gender than the one they were assigned, social isolation from their peers, anxiety, loneliness, and depression. According to the American Psychological Association, transgender children are more likely to experience harassment and violence in school, foster care, residential treatment centers, homeless centers, and juvenile justice programs than other children. Adults with gender dysphoria are at increased risk for stress, isolation, anxiety, depression, poor self-esteem, and suicide. So, before we go on to the diagnostic criteria of gender dysphoria, let's go into the controversy surrounding the diagnosis. So, the previous diagnosis of gender identity disorder caused a great deal of controversy. Many transgender people and researchers supported the declassification of GID, arguing that the diagnosis pathologizes a natural form of gender variance, reinforces the binary model of gender, and can result in stigmatization of the transgender individuals. The official reclassification of gender dysphoria as a disorder in the DSM-V may help resolve some of these issues because the term gender dysphoria applies only to the discontent experienced by some persons resulting from gender identity issues, rather than suggesting that their identity is disordered. Advantages and disadvantages exist to classify gender dysphoria as a disorder, however. Many people argue that the distress associated with gender dysphoria is not caused by any disorder within the individual, but by difficulties encountered from social disapproval of transgender identities and alternative genders. As such, they argue that any form of diagnosis is still stigmatizing and places the problem unnecessarily on the individual rather than on society. However, because gender dysphoria is classified as a disorder in the DSM-V, many insurance companies are willing to cover some of the expenses related to sex reassignment therapy. Without the classification of gender dysphoria as a medical disorder, sex reassignment therapy may be viewed as a cosmetic treatment rather than medically necessary treatment for many transgender individuals, and thus may not be covered. So, that is the controversy surrounding the diagnosis. And like I said, maybe in the next edition of the DSM-V, they may abolish or they may not include already gender dysphoria in the list of mental disorders because of course, the rise of the transgender movement. And of course, we have also the change in social attitudes with regards to gender identity. So, the other surrounding controversies regarding gender identity is, of course, when do we start hormone therapy? When do we start the transitioning of a certain individual? So, in some countries, as young as 4 or 6 years old, they are already permitting the parents to have their children undergone puberty blockers if they identify as with another gender. So that is the controversy because when do we draw the line between the regulation of the state with regards to the gender identity of the individual, and when does the parental responsibility also come in? Because in some countries, for example, if you deny your child the right to, for example, transition, a minor, a child, like for example, below 18 years old or even below 12 years old, the state will get your child and the child will be under the foster care of the state. So that is also one of the issues there. So another issues with regards to gender identity is of course those who detransition. So when we say detransition, so these are people who at first identified as someone of their opposite gender, but then they realize or now they identify as that is in line with their own gender. So of course, these people represents a very small part of the community, of the transgender community or the LGBT community. And of these people who detransitioned also need medical and mental health care, but of course they are being denied because they already transitioned back to their previous gender that they identified with. So those are just some of the controversies regarding the diagnosis, but who knows, maybe in the next edition, they would completely abolish this gender dysphoria section, or maybe another disorder will come up for that, especially now with the rise of awareness and, of course, activism towards transgenderism. So, what is the diagnostic criteria for gender dysphoria? So, of course, let's start with the children first. So, gender dysphoria in children. So, letter A. So, there is a marked incongruence between one's experience or expressed gender and assigned gender of at least 6 months duration as manifested by at least 6 of the following, one of which must be criterion A1. So, 1. A strong desire of the other gender or instance that one is another gender or some alternative gender different from one's assigned gender. In boys, assigned gender, a strong preference for cross-dressing or simulating female attire, or in girls, which is the assigned gender, a strong preference for wearing only typical masculine clothing and a strong resistance to wear typically feminine clothing. Number 3, a strong preference for cross-gender roles in make-believe play or fantasy play. Number 4, a strong preference for toys, games, or activities stereotypically used or engaged in by another gender. And of course, number 5, a strong preference for playmates of the other gender. Number 6, in boys, a strong rejection of typically masculine toys, games, and activities, and a strong evidence of rough and tumble play, or in girls, a strong rejection of typically feminine toys, games, and activities. Number 7, a strong dislike of one's sexual anatomy. And number 8, a strong desire for primary and or secondary sex characteristics that match one's experienced gender. B, the condition is associated with clinically significant distress or impairment in social, school, or other important areas of functioning. And with specifier, with disorder of sex development. For example, a congenital androgenital disorder such as congenital adrenal hyperplasia or androgen insensitivity syndrome. So for gender dysphoria in adolescents and adults, so letter A, a marked incongruence between one's experience or expressed gender and assigned gender of at least 6 months duration as manifested by at least 2 or more of the following. Letter A, a marked incongruence between one's experience or expressed gender and primary or secondary sex characteristics, or in young adolescents, the anticipated secondary sex characteristics. Number 2, a strong desire to be rid of one's primary and or secondary sex characteristics because of marked incongruence with one's experience or expressed gender, or in young adolescents, a desire to prevent the development of the anticipated secondary sex characteristics. Number 3, a strong desire for primary and or secondary sex characteristics of the other gender. Number 4, a strong desire to be of the other gender or some alternative gender different from one's assigned gender. Number 5, a strong desire to be treated as the other gender or some alternative gender different from one's assigned gender. And number 6, a strong conviction that one has the typical feelings and reactions of other gender or some alternative gender different from one's assigned gender. Letter B, the condition is associated with clinically significant distress or impairment in social, occupational, or with other important areas of functioning. And of course, specify if there is a disorder of sex development. So that's why it's also one of the reasons why gender dysphoria may not be abolished or will still be included in the next edition of the DSM, because we also consider people with disorder of sex development, such as there is biological reasons why they strongly feel that they are of the opposite gender, such as the congenital androgenital disorders, such as congenital adrenal hyperplasia and androgen insensitivity syndrome. So if you consider the diagnosis, so especially in children, there is really a very vague, very not clear definition of gender dysphoria in children. That's why I think more research, if you are interested in researching about gender dysphoria, the transgender movement, or any gender related research, so maybe your research can help, especially in giving out a clear line what is a gender dysphoria disorder and what is normal feeling of being a transgender. So I hope that those who are interested with that will be encouraged to do more research, because we need empirical evidences and not merely opinions or not merely feelings regarding this matter. Okay? There are maybe laws that may be passed that would better improve the mental health of that certain minority community. The last part of this discussion will be about paraphilic disorders. So what are paraphilic disorders? So the word paraphilia came from or derives from the Greek word para, means around or beside, and philia means love. So para meaning around or beside, and philia, which means love. Okay? So it is any emotional disorder characterized by sexually arousing fantasies, urges, or behaviors that are recurrent, intense, and also occur over a period of at least 6 months and cause significant distress or interfere with sufferers' work, social function, or other important areas of functioning. This is as opposed to sexual variants, which are sexual behaviors that are not typical but are not part of any illnesses. So, in the DSM-5, the term paraphilia is defined as any intense and persistent sexual interest other than the sexual interest in genital stimulation or preparatory fondling with phenotypically normal, physiologically mature consenting human partners. So paraphilias, however, may not be necessarily classified as intense and persistent, but rather a preferential sexual interest or sexual interests that are greater than non-paraphilic sexual interests. So, what are the types of paraphilia? So, that is included in the DSM-5. So, first one is voyeurism. So, watching an unsuspecting or non-consenting individual who is either nude, disrobing, or engaging in sexual activity. Number 2, exhibitionism. Exposing one's own genitals to an unsuspecting person. Number 3, Frotteurism. Touching or rubbing against a non-consenting person. Number 4, sexual masochism. Being humiliated, beaten, bound, or otherwise suffering. Number 5, sexual sadism. The physical or emotional suffering of another person. Number 6, pedophilia. Sexual activity with a child that is prepubescent, usually 13 years old or younger. Number 7, fetishism. A sexual fantasies with non-living objects or highly specific body parts or partialism. Examples of specific fetishisms includes somnophilia or sexual arousal by a person who is unconscious, and urophilia, deriving sexual pleasure from seeing or thinking about urine or urinating. Transvesticism, cross-dressing that is sexually arousing and interferes with functioning. And Autogynephilia. This is a subtype of transvesticism that refers to specifically to men who become aroused by thinking or visualizing himself as a woman. So, of course, there are also other specified paraphilias. Some paraphilias do not meet the full diagnostic criteria for a paraphilic disorder, but may have uncontrolled sexual impulses that cause enough distress for the sufferer that they are recognized. Examples of such specific paraphilias include necrophilia or corpses, scatologia or obscene phone calls, croprophilia or feces and defecation, and zoophilia or animals. So, urges to engage in coercive or otherwise aggressive sex like rape are not symptoms of a mental illness. Such sexual offending is therefore not considered as paraphilia. So, let's now go on to the DSM, the diagnostic criteria for paraphilias. Okay? So, first is, of course, voyeuristic disorder. So, letter A, over a period of at least 6 months, recurrent and intense sexual arousal from observing an unsuspecting person who is naked in the process of disrobing or engaging in sexual activity as manifested by fantasies, urges, or behaviors. Letter B, the individual has acted on the sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And the individual experiencing the arousal and or acting on the urges is at least 18 years old. So there is a specifier here if it is in a controlled environment and if it is in remission. So in a controlled environment, this specifier is primarily applicable to individuals living in institutional or other settings where opportunities to engage in voyeuristic behaviors are restricted. So we also have exhibitionistic disorder. So same. So over a period of 6 months, there's a recurrent and intense sexual arousal from the exposure of one's genitals to an unsuspecting person as manifested by fantasies, urges, or behavior. Letter B, the individual has acted on these sexual urges with a non-consenting person, or sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, and or other important areas of functioning. So, specify whether there is sexually aroused by exposing genitals to pre-pubertal children, sexually aroused by exposing genitals to physically mature individuals, and sexually aroused by exposing genitals to pre-pubertal children and to physically mature individuals. So we also have the Frotteuristic disorder. So over the period of at least 6 months, recurrent and intense sexual arousal from touching or rubbing against a non-consenting person as manifested by fantasies, urges, or behaviors. The individual has acted on these sexual urges with the non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So it also has a specifier if it is in a controlled environment and if it is in partial or in remission. So we also have the sexual masochism disorder. So over a period of at least 6 months, recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer as manifested by fantasies, urges, or behaviors. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Specified with asphyxophilia if the individual engages in the practice of achieving sexual arousal related to the restriction of breathing, and also if there is in a controlled environment or in full remission. So pedophilic disorder. So over a period of at least 6 months, recurrent, intense, sexually arousing fantasies, sexual urges, or behaviors involving sexual activity with prepubescent child or children generally aged 13 years or younger. The individual has acted on the sexual urges or the sexual urges or fantasies cause marked distress or interpersonal difficulty. and the individual is at least 16 years of age and at least 5 years older than a child or children in criterion A. So note, do not include an individual in late adolescence involved in an ongoing sexual relationship with a 12 or 13-year-old. There are specifier, which is exclusive type, which is they are attracted only to children, and the non-exclusive type. We also have the sexual sadism disorder. So over a period of at least 6 months, recurrent and intense sexual arousal from the physical or psychological sufferings of another person as manifested by fantasies, urges, or behaviors. The individual has acted on these urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And the transvestic disorder, over a period of 6 months, recurrent and intense sexual arousal from cross-dressing as manifested by fantasies, urges, or behaviors. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So specify with fetishism if sexually aroused by fabrics, materials, or garments, or with autogynephilia if sexually aroused by thoughts or images of self as female. Fetishistic disorder, over a period of at least 6 months, recurrent and intense arousal from either the use of non-living objects or highly specific focus on non-genital body parts as manifested by fantasies, urges, or behaviors. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The fetish objects are not limited to articles of clothing, clothes used in cross-dressing, as in transvestic disorder, or devices specifically designed for the purpose of tactile genital stimulation, such as vibrators. So specify if there is by body part, non-living objects, or other. So let's talk about some issues with regards to paraphilic disorders. So how do we know if one thing is only just a quote-unquote kink and another is already a disorder, a paraphilic disorder? So as you can see with the rise of the internet and more information about sex and sex practices are being published online, so there is a gray area between what is considered a kink versus what is considered already a paraphilic disorder. But just remember, in our definition of disorder, so when we say it is already not normal, if it causes distress not only to you but also to your sexual partner, and also it affects your functioning with regards to your social, occupational, or other areas of your functioning, or it means that you cannot function in the bedroom, you cannot function sexually without doing this paraphilic stuff. And of course, maybe, for example, in the case of sexual masochism and sexual sadism, the partner is very distressed with regards to your behavior about your masochism or your sadism. So maybe the partner does not really consent with the extremity of those paraphilic disorder. And another thing to note is that there is also a rise of people who called MAP. I don't know if you heard of them. MAP, or minor attracted persons. So they call themselves MAP, and they say or they claim that they are part of the LGBT community. But of course, the LGBT community does not recognize pedophiles or those MAP people or attracted to that. So of course, there are also issues with regards to, of course, like I said, the kings or something like that. Because, for example, in otaku culture, so lollies, diba? Lollies. So people who look young but they are actually legal, the legal lollies and something like that, or legal shotas. So there is a blurry line between that and what do we consider as a disorder or something that is a kink, because of course that is not the usual or normal or normative way of having sex, right? So, yeah, I hope that more researches will come up so that we can be clear of what is normal from what is non-normal sexual activities. That's it. That's it for the sexual disorders, sexual dysfunction, gender dysphoria, and paraphilic disorders. So I hope you have learned a lot, and I hope that we remain open-minded and curious about the different progressions of disorders and of course the different sexual activities that is coming out now, especially because we have the rise of the internet and people can just search it up of those activities. Okay, so I hope that there is more information about it and more researches about it so that we can finally draw a clear line between what is a disorder and what is not. Okay, so see you on our last video, which is about the neurodevelopmental disorders. And I hope you have learned a lot, especially this matter. So see you on the next video or last video, and goodbye.